Hello, everyone. This is Dr. Andrew Heyman. I'm here on behalf of Da Vinci Laboratories, speaking to you as part of their professional education program. And my background is as a family physician. I'm the director of integrative medicine at the George Washington University. I'm also the chief medical officer of the Metabolic Code. And today I'll be speaking to you on a systems biology approach to the relationship between the adrenals, thyroid, and pancreas, or cortisol, thyroid hormone, and insulin. As part of our professional education series, I will be speaking to you on not just this system, but a variety of subsystems in partnership with Dr. Jim Laval. We have 5 of these triads. This is the first of the 5, and we feel like this particular set of subrelationships is critically important to being an effective integrative practitioner. So, what are our learning objectives? Well, let's explain the characteristics of Triad 1. We'll specify the metabolic activation pathways and define the role of the pancreas, thyroid, and adrenals in the context of chronic illnesses. So, Triad 1, adrenal, thyroid, pancreas. So what are the characteristics of this? Well, fundamentally, if you think about these 3 hormones, cortisol, insulin, and thyroid, they're meant to give us energy. So cortisol confers energy and marshals metabolic resources so we can deal with threats. Insulin helps us to manage carbohydrate control and deliver energy to the cells. And then thyroid is directly important for producing ATP in the mitochondria because it influences the number and functioning of mitochondria overall. When I explain this to my patients, I talk about these relationships in words or vernacular that I think patients can understand. So I would often mention that this is really about stress, metabolism, and sugar. And people kind of get that. So when we're under stress, we tend to reach for carbohydrates and sugars to comfort ourselves, but over time, these changes in our behaviors and alterations in our coping skills can often result in fatigue and slowed metabolism. More broadly speaking, these 3 hormones, cortisol, insulin, and thyroid, function as central regulators of our physiology. You have receptors for all 3 hormones on just about every cell in the body. And so this subunit of set of relationships between adrenal, thyroid, and pancreas is so critically important for energy production, for balancing physiology, and when they're functioning normally, people tend to feel vital and well. Now think about that. That makes sense. If I'm managing my stress, if I'm eating healthy for my metabolism, if my energy packets of mitochondria are producing plenty of ATP, I feel great. I'm well, I'm vital, I have normal body composition, I have good energy, I'm resting deeply at night, and basically I have my sort of lifestyle intact. And I think these hormones in particular really directly do underlie lifestyle choices. How we think and feel, how we move and rest and repair, the daily choices that we make. These are the 3 hormones that are directly influenced by all of those behaviors on a daily basis. Now, if we're under lots of stress, or we're reaching for too many carbohydrates, or we're beginning to influence mitochondrial function and energy production, people start to feel tired, and our metabolism will begin to be sluggish, and ultimately individuals will start gaining weight. We know this is true. Alterations in cortisol production, high or low, has been linked with obesity. Of course, hyperinsulinemia and insulin resistance has been linked with obesity, as well as hypothyroidism has been linked with obesity. And all 3 states are also directly tied to energy and therefore self-reported fatigue. So it makes sense that these 3 hormones interact with each other in fundamental ways. So this is a systems biology approach to how we understand our patients in ways that are practical and clinically meaningful. So when I look at my patients and I talk to them about, do you have plenty of energy? How's your weight? Do you feel like you can complete tasks during the day? Are you able to sleep deeply at night and rest and repair? And if they say, oh, no, you know what, I've been under stress, I'm not eating as well as I should, my energy levels aren't great, I'm just not feeling myself, I'm not feeling vital. Well, then you say, well, you know what, we really got to look at your cortisol, insulin, and thyroid, your stress, metabolism, and sugar, because maybe some clues to what's going on with how you're feeling are related to the functioning of those three hormones. And more importantly, these three hormones interact with each other, that they stand in what we call permanent crosstalk. So when they're functioning normally, we see good balance in people's lives. There's plenty of sort of movement, and we're doing things we want to do, and they have energy, and there's kind of a rhythmicity to these hormones, that they go up and they go down the way they're supposed to. And so as a result, people feel vital and well, and we have meaning and purpose in our lives. And why are we looking at things in these sort of subunits? Because if we evaluate all the important metabolic pathways that possibly participate in why people feel the way they feel, it's overwhelming. Everything is connected to everything else. But within that complexity and cascade of events, we know that there's a very special set of relationships between cortisol and thyroid function and insulin abnormalities. So this relationship between insulin, cortisol, and thyroid function is so important to understand, because one influences the other. And whatever beginning point that you have, whether it's looking at it through the lens of how stress influences the other two, or how insulin influences the other two, how thyroid influences the other two, you can get there in terms of, wow, there's this interactive component that's just part and parcel to how our bodies function. And I think this is a really important slide, because it shows the clinical effects of excess HPA axis activation. We know that cortisol influences the brain, so it decreases neurogenesis and inhibits immune function. I've talked about that in one of the other lectures on stress and neuroinflammation in great detail. We also know cortisol as a catabolic hormone limits anabolic drive, so we see lower growth hormone production as well as reproductive status. In addition to that, cortisol directly injures the blood vessels and induces insulin resistance. So patients tend to have blood pressure abnormalities as well as blood sugar control problems, and then also excess abdominal visceral adiposity. This is the whole game right here on one slide, this notion of that systems biology approach, where how changes in the stress response can create fundamental alterations in other body systems. Now, the outcomes of all this is that we see thinning of the bones, we see typically sarcopenia, so basically muscle wasting, but also fat deposition, the presence of metabolic syndrome or syndrome X, so blood sugar problems in the setting of obesity and blood sugar and lipid abnormalities, cognitive decline because of alterations in the hippocampus and the prefrontal cortex, immune system compromise, which can lead to fractures and frailty, cardiovascular disease, memory loss, as well as infectious complications. So amazing what can happen in individuals with abnormal states of stress. Now, again, in the other lecture, Stress and Neuroinflammation, we go through the progression of how high cortisol states create one set of stances in the body, and low cortisol states can create a different set of stances in the body, metabolically speaking. So it's worth listening to that lecture as well, as I went to this in detail. But this slide is a wonderful summary of the relationship between stress and all of these processes. Now, we know that the adrenals produce cortisol. This happens in the cortex, which is the rind of the adrenal glands. We have two of them. They sit on top of the kidneys. They're about the size of a nutmeg. And then the center of the adrenal is called the adrenal medulla, which produces epinephrine and norepinephrine. So glucocorticoids produced in the adrenal cortex, and as cortisol is released, it's a function of activation of the HPA axis, which begins in the brain through the hypothalamus, which then triggers the pituitary, which releases ACTH, which then turns on cortisol production. And we can have various stances of cortisol in the body, whether there's overproduction, so hypercortisolism, or hypo production, or low cortisolism, which really, as we term it, is a low allostatic load state, meaning that the body has gone into this self-defense mode where the brain and the rest of the body has said, you know, enough is enough. I've had too much stress. You've made too much cortisol. It's altered or even injured key centers of your physiology. So to further protect myself, I'm going to turn down the stress response, and we'll go into a flattened cortisol curve. Now, one of the other features of this can be, as I've mentioned in the stress and neuroinflammation lecture, is that a flattened cortisol curve may be the result of an immune threat, that the body has decided, I'm going to turn down the stress response to liberate or free bodily defenses so that the immune system is more hypervigilant. So you always have to ask yourself the question, what's the state of cortisol? How does that relate to other body systems and compartments, including the immune system? So how did I get there? Was it from stress? Was it from an immune threat? Was it from some other pressure on metabolism? Now, cortisol levels should follow circadian rhythm, and that means there's metabolic homeostasis, and the rhythm is high in the morning and low at the end of the day. And of course, cortisol fits into the regular hormone cascade of glucocorticoids, as well as reproductive hormones. There are many mediators of the stress response, and so stress in the short term influences cardiovascular output. We also see elevations in blood sugar. This is important because if you're running away from the tiger or trying to fight it, you want a ready supply of glucose in the bloodstream to feed the skeletal muscle. So no wonder there's sort of this temporary insulin resistance that occurs. Now, obviously, over time, if there's chronic stress, we, of course, as a result, see chronic elevations in blood sugar as well. So that is a maladaptive consequence of ongoing stress. So there's this relationship between stress and blood sugar control. But as a result of these temporary fluctuations with short-term activation, the muscles become energized, and rightly so. But instead, if stress is more chronic, there are long-term consequences, meaning more permanent abnormalities in blood sugar, protein wasting, immune dysfunction, mineral loss, as well as changes in kidney function and blood pressure as well. So we know that the stress response really should activate and go back to normal, activate and go back to normal. But if it doesn't go back to normal, or if there's more permanent alterations in the stress response, this has dire consequences for a variety of other body systems. Now, interestingly, when we eat, cortisol levels also go up. And this is important to note because eating is in some ways a stress on the body. And you may ask yourself the question, well, why does this happen? Why do cortisol levels start to go up when we eat? And the reason for this is because the body is trying to create a blunting mechanism in its glycemic control. So as insulin levels climb when we eat, we see glucose levels begin to alter, first high and then low. And there are some individuals that as they're starting to get into trouble with abnormal insulin response, they develop the early stages of what's called hypoglycemia, meaning a rapid fall in blood sugar. So how does the body blunt against this? Well, it raises cortisol because cortisol helps to create temporary insulin resistance. So this happens normally every time we eat. Blood sugar goes up, insulin goes up, but so too does cortisol as a secondary consequence. And there are many metabolic effects due to chronic cortisol activation. So as I said, bone and mineral loss, insulin resistance, increased fat deposition, alterations in immune function. Let me stop there. When cortisol levels go up, we tend to be Th2 dominant, which means mast cells are more active, there's greater histamine release, and we're more atopic. Allergies, asthma, and eczema. That's really important to understand. But of course, cortisol is catabolic. So there's degradation of muscle tissue, but also the lining of the gut, the endothelial lining as well, even the blood-brain barrier, and certainly key centers in the brain. I've talked at length about changes in the hippocampus, the prefrontal cortex, the amygdala, because of the direct action of cortisol on tissue, including the central nervous system. That is really important to understand. So cortisol also has a direct effect on the thyroid, but it also, because of its catabolic nature, it can induce the bone loss and mineral loss, sodium and water retention, elevated lipids, but of course it interferes with sleep because it's activating the brain. It can accelerate plaque formation, increasing cardiovascular risk factors and receptor site activation on tumor cells, memory loss because of its direct impact on the hippocampus, and then suppression of sex hormones, mental and emotional instability. This comes from changes in the prefrontal cortex and the amygdala. It is amazing how stress can influence the body, and in particular, insulin response and thyroid function. So what's a clinical representation of this? Well, think about athletes. So what is physical activity? It's a metered dose of stress. So we say, I'm going to create an effort for this much intensity for this period of time. And then we have to rest and repair. So what does that mean? It means that all of our stress systems are turning on when we're exercising, but we need to have adequate downtime to let the anabolic drive take over. But what happens in overtrained individuals, meaning they're doing too much exercise, they're not allowing for rest and repair? Well, that means they're just in a chronically metabolically stressed state. And this overtraining can lead to neuroendocrine immune imbalances. So as a result, there's an increased baseline of inflammatory cytokines. There's loss of anabolic hormones as well, so there's lack of repair. Usually what happens is when we stop exercising, there's a release of these anabolic hormones and cortisol, which are reported to be elevated 15 to 30 minutes post-resistance exercise. So the body automatically goes into that repair mode. But overtraining has been associated with sleep and mood disturbances, inflammation, immune imbalances, fatigue, and insulin resistance. And that moderate, regular exercise actually improves anti-inflammatory cytokines release. And that makes sense, that when an individual commits to too much exercise, we see activation of all these stress pathways. And if they don't give themselves adequate time to rest and repair, they go into this more kind of permanent overtrained state. And that's exactly what we see. So athletes can get there, but also people who just have lots of stress and they don't give themselves enough downtime also end up in. So athletes get this term overtrained, but we could say, when you measure the metabolic activation pathways in people who have been under stress for other reasons, they look identical. They have the same inflammatory drive, the insulin resistance, the low thyroid, the loss of anabolic hormones, the lack of libido and low sex hormones. It's all the same. However we get there. So the body is sort of organized around these complex reactions and interconnections. And of course, exercise is one way to sort of overstress the system, which makes sense. And I've mentioned before, when cortisol levels are high, we're Th2 dominant. So we have atopic illnesses, excess histamine release, the body becomes leaky. When cortisol levels are low, we tend to be Th1 dominant. So that means there's a predisposition to autoimmunity and cancers. So I always ask myself the question, what's the stance of the stress response, and does this have import on the immune system itself? Now, in addition to that, cortisol has a very important role to play in thyroid balance. So cortisol in its overexpression will interfere with the conversion of free T4 to free T3 and actually will shunt T4 into reverse T3. So when the body is under stress, we see elevated reverse T3 levels, which of course are more of the metabolically inactive forms of T3. And you say, well, why does that happen, Dr. Heyman? Why is it that stress will blunt thyroid production? and shift thyroid into this sort of more inactive state. What the literature suggests is that if you're under high states of stress and you've activated your sympathetic nervous system, among other things, that will be activating the sinoatrial node of the heart. So we see increased cardiac output, peripheral blood flow, oxygenation of the peripheral tissues. All great. But you can imagine if that's already happening, we probably don't need excess free T3 floating around as well. That as the body migrates into this hypervigilant activity, we probably don't necessarily require an additional input of T3 on various bodily systems, including the cardiovascular. So what does this look like, again, in a clinical study? Well, when we look at exercise intensity and thyroid hormones, this is a 2005 study in 60 male well-trained athletes. They looked at intensity of exercise and then measured their thyroid hormone levels. So they compared thyroid hormone at 45%, 70%, and 90% of maximum heart rate. And they specifically measured TSH, T4, and free T4 levels, which increased at 70 and 90% versus 45%. And free T3 and T3 increased at 70%, but fell at 90%. And this was thought to be due to elevations in cortisol, that there's this sort of sweet spot in terms of 70% of maximum heart rate. You have real efficiency in the thyroid, but as you get into the 90% of maximal effort, we see a fall in free T3 because cortisol starts to blunt the conversion of T4 to T3. So there are also metabolic effects of suboptimal thyroid function. So we know that low thyroid has been linked to glucose tolerance, meaning that thyroid hormone influences the rate at which glucose is absorbed from the GI tract and taken up by the cells, and that insulin signaling and receptor problems also arise from low thyroid, which reduces target insulin binding and number of insulin receptors expressed. So free T3 in particular is very permissive for the number of insulin receptors that are available, as well as conformationally how receptive those receptors are to insulin itself. So free T3 is so important for normal glucose control. In addition to that, low thyroid function has been linked to cardiovascular issues. So we see decreased metabolism of fats and increased serum lipids, decreased availability of cardioprotective essential fatty acids, inadequate T3 lowers oxygen consumption, contributes to lipid peroxidation, free radical damage, and subclinical hypothyroidism is an independent risk factor in atherosclerosis and myocardial infarction. So it's so important. So if you have a patient who, let's say, is cardiometabolic in nature, they have hyperlipidemia, hypertension, obesity, you may want to check their thyroid levels. I think that's really important to recognize. So let's get back to cortisol. So cortisol is important for sleep, and cortisol release is controlled in slow wave sleep by decreases in corticotropin releasing hormone and increases in growth hormone. Exposure to chronic stress imbalances the HPA axis and disrupts normal diurnal patterns of growth hormone, CRH, and ACTH release in the pituitary, results in a paradoxical rise in cortisol in the evening hours and initial sleep phases. So nocturnal hypocortisolism, so high cortisol levels at night, can lead to sleep fragmentation, increasing cortisol even more. So the body gets into this sort of hypervigilant state. It is not able to transition into rest and repair mode. And so the immune system remains hyperactive as well with neuroexcitation. The brain cannot settle down, and therefore we can't enter into slow wave sleep and REM sleep. This is a disaster for patients because they really never turn off at night. So it's so important to measure cortisol levels and determine do they have the right amounts of cortisol at the right time, and if they're elevated in the evening, we need to do something about it. So HPA axis dysfunction, cortisol and cholesterol metabolism, chronic stress and elevated cortisol are correlated with cholesterol imbalances, and that means just like hypothyroidism is linked with hyperlipidemia, so too is chronic states of stress. In addition to this, of course, stress has been linked with metabolic syndrome because it's correlated with dysregulation of the HPA axis. So morning serum cortisol is reported to be increased in those with metabolic syndrome, and that cortisol increases risk of MET-S at both central and peripheral levels. And this makes sense because of the bidirectional relationship between cortisol, glucose control, cortisol, cardiovascular function, cortisol, and obesity. All of this, it can be mediated to one degree or another because of stress. So here's a 2013 clinical study. This actually looked at hair cortisol levels, and there was a higher prevalence of metabolic syndrome or MED-X, or cardiometabolic disease, as it's now been renamed to some degree, reporting those with elevated long-term cortisol secretion. So think of hair samples as sort of your A1C for stress, and that in fact it does reflect the last 3 months of cortisol output. So in individuals who had higher cortisol output, historically, they had a greater likelihood of having cardiometabolic disease, and that makes sense. Cortisol is also important because it can create changes in acid-base regulation with excess lactic acid production. So when we have a lower pH in the body, we start stripping out minerals from the bones to buffer the lactic acid in the blood, which can lead to decreased bone mineral density. And also, if you pair that with a functional vitamin D deficiency, this too has been correlated with acute stress. So stress can suppress vitamin D, stress can strip bones, and therefore it's been linked with frailty and fractures. In addition to this, alterations in the HPA axis, especially flattening of the cortisol curve, so patients who are now Th1 dominant, have also been linked with autoimmunity. So they see increased cytokine production, including IL-6, IL-1B, and TNF-alpha, which contributes to the presence or exacerbation of autoimmune processes. What does this look like clinically? Well, here's another 2013 study, 77 patients with MS, 34 controls. They evaluated the diurnal cortisol release, which was assessed in saliva. And what they showed is that alterations in the circadian rhythm was associated with relapsing, remitting multiple sclerosis. And so we see this relationship where if you have a diagnosis concurrent with alterations in the HPA axis, especially with flattening of the cortisol curve, you tend to have worse symptoms related to that chronic illness and even heightened mortality. So for example, in a variety of clinical outcome studies, breast cancer patients were also evaluated with saliva cortisol curves. And what we found is there was greater risk of metastases and mortality in those patients because of flattening of the diurnal pattern. So in just about every disease process that we see, if you have flattening of the cortisol curve and alterations in the HPA axis, you tend to have more symptoms and worse outcomes overall. And again, this is not only true in breast cancer, but it's also been associated with leukemias, endometrial cancer, prostate, pituitary, and even lung cancer. So chronic stress and immunodysregulation reported to increase incidence of cancer metastases because of Th1, Th2 imbalances, decreased T cell responses to mitogen stimulation, and impaired natural killer cell cytotoxicity. So when we have patients under chronic stress, and especially when we flatten the cortisol curve with permanent alterations in immune vigilance and immune activity, it is terrible for patients with cancer. And again, cortisol secretion correlates with diabetic complications. So when we have elevated free urinary cortisol, serum cortisol, and hypertension with 1 milligram dexamethasone overnight suppression tests, versus controls, cortisol levels at 12 p.m. related to retinopathy and neuropathy. So again, when you have the presence of a chronic illness like diabetes, if there are changes in the HPA axis, the outcomes tend to be worse in addition to complications. Now, this is a fascinating study. Let's just look at blood sugar itself for a moment. So this was a Kaiser Permanente study. This was published in 2007. And this was, to me, 2008, excuse me. This was a really important study. When you look at the size, 46,000 lives. These were individuals that were followed with their fasting glucose levels. And they were assigned to one of four categories: a fasting glucose of less than 85, 85 to 89, 90 to 94, or 95 to 99. And they were followed until they developed diabetes, died, or left the health plan. or until 2007. So basically, it was a 10-year study. And then they did regression analyses to evaluate the risk of incident diabetes. So they looked for new onset diabetes in this patient population. And what they found, I think, was extraordinary. So for every glucose rise of 1 point above 84, it was correlated with a 6% increased risk of developing type 2 diabetes. So insulin resistance, which leads to type 2 diabetes, is developing at least a decade before detection by traditional lab markers. So that means that as blood sugar is starting to climb, even in the 80s, 85, 86, 87, you have an additional 6% increased risk. By a fasting blood sugar of 90, they already started to see microvascular damage in the eyes and the kidneys. Extraordinary. So we really try and tightly control blood sugar, but to control blood sugar, you also have to control stress, because if you have these swings and episodes of hypoglycemia, you know you're going to activate your stress response. So you get this bi-directional relationship between cortisol and insulin. And so it's not just enough to get the carbs out of the diet, it's really important to also manage and modify stress as well. So every food that is eaten influences the production of hormones in the body. I mean, this is just one of these permanent issues. And so how we eat, the context of what we eat, and what we eat all has to do with our glycemic control. So let's get back to this framework of Triad 1, Adrenal-Thyroid-Pancreas, cortisol, thyroid hormone, insulin, stress, sugar, metabolism. So important as a set of interrelationships. We just went over a variety of metabolic and clinical studies to suggest and show that there's this set of relationships that occur. And now when we put this in a clinical context, you'll begin to see how this results as an expression in your patient. Stress, metabolism, sugar. I repeat this over and over and over in my patients. And I draw triangles and I show them the patterns of their expression and the ways in which things have become abnormal. Now, normal physiology, as we've mentioned, conferring a sense of vitality and well-being. It means that we have good conversion of glucose to glycogen. Insulin is helping with limiting fat and protein to glucose changes and facilitates cell uptake of glucose. Cortisol helps to regulate protein and carbohydrates and lipids and nucleic acids. It's working as a nice anti-inflammatory. It's conferring energy production. And then thyroid stimulating metabolism overall by stoking the fires of the mitochondria so that we have adequate ATP output, which contributes to good protein synthesis and supports growth and activity throughout the body. Now, we can have, as a clinical presentation, a primary disturbance and a single elevation in insulin. So individual who might just be eating too many carbohydrates, and so they're getting a little bit of blood sugar problem. Conversely, you can also have an individual who's just under acute stress, and there's no real impact on the other two features of this triad. And then finally, you can have an individual who presents with just a singular hypothyroid issue. All of that is possible. Now, I would argue that our patients tend to be sicker than this. They're usually more progressed. And when they're not feeling well and their energy levels are declining, they're starting to gain some weight, this is when they start seeking out an integrative and functional and anti-aging provider because they want greater insight into what might be going on with their metabolism. So what happens when you have an individual who's driving abnormalities within this triad through pressure initially on blood sugar response? So this is what I would call a secondary disturbance, that the main feature of this presentation is someone who's got some blood sugar problems, but there will be some changes in their cortisol and thyroid production as well. So the initial problem has to do with insulin response, which can lead to weight gain, postprandial fatigue, carb cravings, irritability and shakiness, recurrent infections, and so on and so forth. As a response to this, when they're getting swings in their blood sugar, no wonder we see activation in their cortisol levels. So they may start feeling a bit wired and tired, they have poor sleep, central obesity, and some mind racing, all because of cortisol activation. And then the consequence of insulin and cortisol changes can also have a direct impact on thyroid. So patients may also feel cold intolerance, diminished cognition and mood, feeling heavy and sluggish, and difficulty starting the day. Now, how might they present lab-wise? This is the pattern that we're going to see metabolically in this classic early presentation. And I'm saying early on purpose, that this is just someone who has some blood sugar issues that are beginning to reach into adrenals and thyroid. So you may find an elevated fasting insulin or on challenge, elevated fasting glucose, and potentially some elevated liver enzymes. On assessing their cortisol levels, they'll have a slightly elevated cortisol, and then finally a normal to slightly elevated TSH, potentially depressed T4 and or T3, but no presence of TPO and thyroglobulin antibodies. So what might this look like clinically? So let's take a look at Sue B. She's insulin dominant. She's our 36-year-old IT specialist who travels weekly. She loves to eat mostly at restaurants due to work. She requires frequent snacking on protein and candy bars for energy. She complains of foggy thinking and recurrent yeast infections. She notices some weight gain, low energy, but still able to complete tasks. She complains of achy joints and can't work out as a result. I feel like I have highs and lows and my brain is like soup. Just don't tell me to stop eating sugar. So there's your sign. Okay, she's starting to become a carboholic. She's relying on that to get through her days. And it sounds like she's beginning to have swings in her energy, which results in foggy thinking, some weight gain, recurrent yeast infections. And she's getting some shudders, therefore, in this first triad. And you wonder, well, how far has she progressed? So let's move on from this, though. So if you have someone who is under acute states of stress, so now we're migrating over to cortisol, we see changes in TSH, limiting conversion of T4 to T3, loss of tyrosine and selenium. Why does that happen? Well, we're activating our sympathetic nervous system, and we're beginning to deplete the precursor of tyrosine for epinephrine and norepinephrine, as well as alterations in selenium pools and elevations of reverse T3. This also will create changes in insulin homeostasis with worsening insulin sensitivity, reaching for carbohydrates, loss of serotonin production as a result, and weight gain and central obesity. And don't forget that with activation of cortisol, there can be hippocampal atrophy, alterations in immune response, increased levels of IL-6 and TNF-alpha, especially in low states of cortisol, and then lower DHEA. Well, if this patient progresses to a flattened cortisol curve, it's even worse. As I've said, when that occurs, likely there have been changes in the central nervous system. The patient is now Th1 dominant. They have higher levels of CRP, IL-6, and TNF-alpha, and we're creating much greater pressure on blood sugar response and thyroid function. So these patients are going to be exhausted. They have poor sleep, higher levels of inflammation and achiness, low mood, and memory. They also will typically feel cold, diminished cognition, feeling heavy and slow, as well as consequences in insulin status, so weight gain, postprandial fatigue, and carb cravings. So what are we going to measure in these patients? Well, the primary driver now is their flattened cortisol curve, and which means that there's loss of rhythmicity. We may see either high or low DHEA, in addition to commensurate changes in thyroid function, so a slightly elevated TSH, suppressed T4, T3, but still no presence of immune activation yet. Now, think about this. Sue B had high blood sugar and a slightly elevated cortisol. If you follow the literature, she's not quite at risk yet for autoimmune problems. But this patient who has flattened their cortisol curve, they will have risk for autoimmune conditions because now they're Th1 dominant. So even though this person is not expressing, for example, an autoimmune thyroiditis, they could and they may. And if this goes on unchecked, maybe they will. So that's the kind of discussion that you need to have with patients to say, well, you know what? You've kind of blown through your stress response. And this has implications for how your brain functions, how your immune system functions. It has clearly altered your thyroid status and your blood sugar and created additional risk because now you've liberated your immune system, you're Th1 dominant, and I worry where you're going in the future. Things are quiet now, but I'm not so sure where things are going to be at. So what does a patient like this look like who's cortisol dominant? It's Frank J. He's our 48-year-old executive who works 70 to 80 hours per week for as long as he can remember. His wife complains that he doesn't sleep well at night. He's lost interest in activities due to weight gain, a pesky ankle injury, and lack of energy. He grudgingly notes that his mind is not as sharp as it used to be, and, quote, neither is his body. Frank feels tired and soft inside and out, and he reports decreased libido. Okay, so we've gone through insulin dominant, cortisol dominant, and now let's look at centrally suppressed thyroid function. So what happens as a consequence of this? Well, there's poor conversion of cholesterol to pregnenolone, so we see alterations in hormonal status. Low thyroid means low mitochondrial number, loss of ATP production, lack of insulin sensitivity. Remember when I said T3 levels are so important for insulin receptor activity, but now there's higher levels of oxidative stress and lactic acid production as well, so pH levels are dropping. All of this then can lead to depressed cognition, mood, and memory, reduced cardiac function, slow gastric motility, and loss of mitochondrial numbers and productivity. So thyroid dominant, what are the symptoms? Well, they look a lot like cortisol dominant, meaning cold intolerance, diminished cognition and mood, feeling heavy and slow, fatigue, poor sleep, inflammation, weight gain, fatigue, and carb cravings. But what do the numbers look like? Well, this is a progression once again. Now they have frank elevated levels of TSH and depressed T4 and T3 and presence of TPO or anti-thyroglobulin antibodies. So the immune system is now even more activated in the context of this final progression of thyroid dominance. We might see mixed salivary patterns in their stress response, slightly elevated fasting insulin, and elevated CRP. So who does this look like? Well, Betty R. Betty's a 52-year-old housewife who loves to cook. She follows the food pyramid closely, utilizing plenty of grains, pasta, dairy, and meat, with only occasional snacks and treats. She prides herself on feeding her children healthy, balanced meals and ensures that they are on a low-fat diet. This is classic for the 1980s and 90s. She noticed recently some spread around the middle, but can't seem to lose weight despite the effort. She's having trouble getting started in the morning and feels creaky. Since her energy levels were low and she can, quote, never get warm, she was diagnosed with hypothyroidism. And a well-meaning practitioner started her on Armour, but she feels just as sluggish as ever, even though her TSH is now normalized. Now, who has had that situation? You think, okay, I got it. You know, she's getting a bit older, her thyroid has become a bit sluggish. Let's get her on some Armour. Let's boost her T4 and T3 levels. No big deal. She's going to feel great. Well, her numbers are better, but she's not feeling better. And what that really means is there's just more work to be done with her. So what are all your potential choices with respect to managing this complex of adrenal-thyroid-pancreas? There are many. You have many options and solutions. And our recommendation is you choose the ones that relate to the stance of the patient. And there are a number of choices that are at your disposal, depending on what you find with the patient. So let's go back with Sue B, our 36-year-old IT specialist who loves to eat. She's getting swings in her blood sugar, and she's having highs and lows. What does she look like in terms of her labs? Well, her fasting insulin is 50. That's incredibly high. So hyperinsulinemia is 22. We prefer to see her insulin around 2 to 6. And her fasting glucose is 95. Now, based on the Kaiser Permanente study, she's way too high already. We'd like her to at least be below 90. Her morning cortisol is 19, which is a bit activated. 11 to 15 would be more acceptable. At some point, of course, we would also want to get a saliva cortisol sample, but sometimes you can just get blood. And then looking at her thyroid numbers, her TSH is slightly elevated. T4 and T3 levels are at the low end of normal. There's no presence of autoimmune antibodies, and her ferritin is 75. So what's our clinical strategy for someone who's in an early stage of change in this first triad of adrenal-thyroid-pancreas? Well, we really want to focus on the primary driver of this problem, which is breaking her insulin resistance We want to help her manage her stress response and also enhance thyroid function. And you will find that there's a discipline to this approach, that we don't just treat one thing. We sort of honor the fact that this is happening in a context, that there are multiple shifts occurring simultaneously, and we need to touch therapeutically all three corners of the triad. So even if there's a dominance of one area and the other two are just kind of secondary and even mild at best, the clinical strategy is to make sure that you give attention to all three. It's just where you put your emphasis that matters. So what sort of a diet do you might want to recommend for her? Low carb diet, low glycemic diet probably makes the most sense. You may want to consider a low allergy diet, but she doesn't have a lot of immune activity going on, so that's probably less important than just getting some of the carbs out. So we like the modified caveman diet, basically 60 to 90 days of very low carbs, then we start adding in carbs as needed, or a low glycemic diet and gluten-free diet. What if she has some evening carb cravings? Well, it's okay to add in 1 to 2 servings of low GI carbs in the evening. That helps boost serotonin production. She's going to sleep more deeply at night. And a lot of the literature is now showing, especially with the very low carb diets or ketogenic diets, that after 60 or 90 days, the gut starts to break down. And patients need to add back in some resistant starch so that we feed the gut lining. We are able to build resolvins and butyrate so that you have healthy colonic tissue and a normal immune status. But if this goes on for too long, many patients will start to see a diminishment in thyroid function, their mood starts to drop, and counterintuitively, they can start gaining weight. So some patients tolerate a very low carb diet quite well, but you're going to find there are other patients, probably more so, who can't maintain it for too long a period of time. So you're going to have to start adding in some healthy carbs at some point because the brain requires and needs some healthy carbohydrates. So what are we going to do in terms of beginning to balance her blood sugar and insulin response? So if her blood sugar is above 90, but there's no frank insulin resistance and her cortisol levels are slightly elevated, you got to add back in the trace minerals and nutrients to build her alkalinity, because if she's already starting to strip out minerals from her bones or waste selenium and zinc and magnesium through her kidneys, we know that her metabolic efficiency is going to decline. We like a variety of factors to really target in blood sugar control. I use a lot of Trimag in my practice. This is a wonderful product from Da Vinci, which has several different forms of magnesium. Magnesium is so critically important for blood sugar control. Chromium GTF, there's many different forms of high quality chromium on the market, 1,000 micrograms in the morning and 500 micrograms in the afternoon for at least 60 days, and then 500 micrograms twice a day. And then finally, vitamin D3 to tolerance, basically a serum level of 60 to 80. That's optimal for blood sugar control. If they have an insulin of over 22 and an elevated cortisol, you may need to add in some alpha lipoic acid as well. And if no improvement, you could also always consider citrus bergamot, bitter melon, other choices like berberine. You're just going to have to get heavier and deeper in terms of managing that growing insulin problem. Now, diet is central. Diet is key in this situation, but this patient is going to need some additional support in terms of the big three: magnesium, chromium, vitamin D, as well as maybe some other factors that help with blood sugar response. Here's a key concept. If the patient is not losing weight after 60 days, you want to add some fish oil, 1 to 2 grams twice a day, or sterols and sterolins to decrease inflammation. This takes advantage of improving free fatty acid shuttling from the periphery so they can burn off some extra fat. It used to be, when you look at the literature on the role of fish oil in diabetes or insulin resistance, there didn't seem to be a great role. But now we know that fish oil is really important for stoking the fires of burning fat and helping people lose some weight when they're in this situation. What do you do about her thyroid? Well, it wasn't a big feature of her illness complex. You're not going to have to push too hard in this area. Well, you have to ask yourself, does she have some symptoms? If no, even if no, I suggest adding some selenomethionine and some iodine. There's a variety of different agents or compounds that are now available to increase selenium levels and improve iodine, both of which are really important for good thyroid function. If she has lots of symptoms, you could always consider some sort of glandular or prescribed medication to give her back a little bit of thyroid function. And you may want to consider iodine up to 3 milligrams for 2 months and then decrease to 1 milligram. I am not a big fan of very high dose iodine replacement, but I think a little bit of iodine probably goes a long way in these patients. Don't forget that ferritin is critically important for good energy production, mitochondrial function, and thyroid control. So if you measure ferritin levels and they're less than 80, you can give ferritin back. You don't have to necessarily do iron. These are 5 milligram capsules, 6 caps daily for 60 days and 3 taps daily. If her ferritin's 80 to 100, you may want to do a little bit of ferritin, 2 to 4 caps daily. Key concept. Don't forget that chromium is required for conversion of T4 to T3. So not only does it open insulin receptors, but it also creates thyroid efficiency. So we like chromium quite a bit in this situation. We use a lot of chromium in our practice. So what do we do about elevated cortisol? Well, for anxiety, if they have anxiety and mind racing at night, I will add some theanine to help decrease that hamster on a wheel. So L-theanine is a green tea extract, usually 200 to 400 milligrams, 1 to 2 caps, 2 to 3 times as needed. But for sort of baseline elevated cortisol control, I really use a lot of magnolia and philodendron. This is just a mainstay in my practice because it helps to lower cortisol levels. It raises DHEA. If the patient has irritable bowel, I may switch to holy basil because holy basil is so good for calming the gut. And then for sleep problems at night, phenyl-GABA or GABA to help sedate the brain and induce deep sleep. So my big 2 drivers for stress management is magnolia philodendron and L-theanine. Key concept. If insulin resistance cravings and stress, then we add some tryptophan, 500 milligrams 3 to 4 times a day to boost serotonin levels. So this is really important. Now, tryptophan can be a little sedating in these patients, but if they're already activated, tryptophan can be very calming to the brain and elevate the mood. So what are we going to do for SUB? Well, let's get the carbs out of the diet, replace trace minerals and vitamins. Because our insulin levels were so high, consider alpha-lipoic and maybe even bitter melon or another botanical of your choice. For a thyroid, some selenium, methionine, and iodine, as well as some ferritin support to create efficiencies there. And then to help to control our stress, magnolia and philodendron, holy basil, tryptophan. You could even consider some L-theanine too. So now let's move on. This is a progression. Remember Frank J? He's lacking vitality, libido, and intellectual drive. He's burned out, stressed out, and checked out. He's got weight gain, poor sleep, and beginning to struggle. Now, he has flattened his cortisol curve. He's in much dire consequences than SUB. Why? Because of central changes in his stress response, activation of his immune system, and therefore greater pressure as well on his thyroid and insulin response. So you could imagine that he's going to have worse outcomes than a SUB because he has greater metabolic load on the system. So he's in more dire straits. What do we see for his blood sugar? Fasting insulin is 21, so he's becoming hyperinsulinemic. His fasting glucose is 97, so there's some real work to be done there. Now, when we look at his thyroid, his TSH is low. You say, oh, that's okay. But wait a minute, his T4 and T3 are low too. So now he's got this central suppression of the HPT axis. This means that stress has been a bigger feature of his illness complex. So where do we put our emphasis here? Well, to all 3 points of the triad, but in particular, we want to create emphasis on the central stress response, manages growing insulin resistance, and limits stress on the thyroid. Dietary advice can be similar to SUB. Get the carbs out of the diet, no grains, gluten, and dairy. If he's got evening carb cravings, 1 to 2 servings of low GI carbs at night. What do we do for flattened cortisol curve? Well, you always want to start with an adaptogen, and there's a variety of these that are at your disposal. Ashwagandha, rhodiola, ginseng, maca, cordyceps. They're all pretty good, but you definitely want to get a patient on an adaptogen to help their brain and their bodies cope with this ongoing stress and neuroinflammation. In addition to that, they might need some DHEA support. So in women, it's 5 to 25 milligrams, and in men, it can be up to 50 milligrams to decrease that neuroinflammation, induce a sense of well-being, begin to re-regulate that stress response. In addition to that, you may want to consider some adrenal extracts. I like to choose based on whether or not they have excess anxiety. If they do, you might want to look for adrenal cortex extract. which does not have the excess neurotransmitters in it. It's only the cortex. And if they don't, if they need the whole gland, you can find a whole gland. Key concept, if patient reports difficulty sleeping, you can always add some additional glandulars. There's one called neuromedulla, which is 2 caps at night to reactivate the hypothalamus. In addition to this, if patient reports depression and fatigue, you want to add tryptophan to restore serotonin levels. We know what you need to do with respect to his insulin management. You have a good multivitamin and mineral, that is baseline and key, then magnesium, chromium, vitamin D as well to really rebuild the 3 key drivers on a nutrient level for insulin response. If you need to add in some additional lipoic acid, bergamot, bitter melon, berberine, those sorts of things, you can do that too as you're gaining control of his blood sugar. What are you going to do for subclinical hypothyroidism? Well, if there aren't a lot of symptoms, selenium-methionine, but here we also add tyrosine. Why? Because he's flattened his cortisol curve. So we know that there's probably been some wasting of this key neurotransmitter. There's likely flattening of his affect, and therefore we need some additional tyrosine to boost his dopamine levels. So 500 to 1,000 milligrams twice a day. If he's got a lot of symptoms, you may even want to add some sort of glandular to help boost his thyroid as well. But don't forget the selenium-methionine iodine, the tyrosine. So key concept, you want to add tyrosine when adrenals and thyroid are low due to preferential consumption under times of stress. So what's our treatment regimen for Frank J? Well, caveman diet, trace minerals and vitamins. You want to do things to really gain control of his thyroid function. In addition to that, for his thyroid itself, selenium-methionine iodine, tyrosine, and even thyroid glandular, potentially even low dose, 15 to 30 milligrams. And then finally, for his stress and adrenals, an adaptogen, magnolia philodendron, tryptophan, and DHEA. So a little greater emphasis on the stress response, a bit more support for thyroid for him. But in addition to that, you still have to focus on diet and lifestyle choices as well. Then what does thyroid dominant look like? If you remember Betty R., she's the one who loves to cook. She follows the food pyramid. She was treated with Armour thyroid. She has weight gain and cool extremities. The big change with her is, sure, she's got a flattened cortisol curve, but now she has the presence of autoimmune antibodies. So we've invoked the immune system. This is a worsened circumstance compared to Frank J. and certainly compared to Sue B. So this is our third progression. Now we've called in another feature outside of the triad itself. Her numbers look similar to Frank, except for the fact that her thyroid is starting to be attacked by the immune system. So we have more work to do with her. So this means we have to treat all of her thyroid abnormalities, manage the growing insulin resistance, and support the stress response. So once again, if there are evening carb cravings, 1 to 2 servings of low GI carbs at night, that's okay. It'll help her sleep deeply at night. You really want her to do that. She's very catabolic at this point. If she's hypothyroid, is there a presence of TPO? If not, you can do selenium-methionine iodine, tyrosine, and a glandular, just like we did with Frank. If the immune system has been activated, then instead, selenium-methionine iodine, tyrosine, and I would switch this patient to a compounded T4, T3, or singularly prescribed T4 and T3. Why? We have to get the glandular out of the system. It can be exciting the immune system and therefore worsening her autoimmunity. I've seen this over and over and over in my practice. I mean, why would you give a person a whole gland if their immune system has already decided that that's something to attack? Now, once we calm things down and hopefully reverse her autoimmunity, you can always consider adding back in a gland if the patient needs it. I'm not against glands. It's just a thoughtful approach to the consideration of, what might be really wrong with this patient and how do we deal with it. Now, it also begs the question of, if there's a presence of these TPO antibodies, how do we manage this autoimmunity? Well, I suggest seeking causative factors. And that means looking at food allergies and sensitivities, the presence of toxins such as heavy metals and chemicals, also evaluating for chronic infections such as Epstein-Barr, CMV, and in my neck of the woods, I've seen many, many, many patients who have an underlying tick-borne illness such as Lyme disease, for example, and also just stress. So again, flattening of the cortisol curve can lead to a predisposition for autoimmunity, so you may really need to focus on re-regulating her stress response to dig her out of this autoimmune state. So these are all the additional pressures that can be in place that have ignited the immune system to misbehave. And it makes sense because think about it. If she was under a lot of stress, this can degrade the gut lining and predispose to food sensitivities. If she has a flattened cortisol curve, that might indicate the presence of a biotoxin or chronic infection, which can be linked with autoimmune issues. And or if she's just had biochemical exposures to heavy metals and fumes and dyes and solvents and VOCs and those sorts of things, they too have been linked with autoimmune thyroiditis. So you might need to really clean up her gut, detoxify the patient, manage her microbial burden, and also help rebalance her stress response. These are the 4 pillars of dealing with autoimmune processes. And the hope, of course, is that you can restore normal immune function. Now, these are foundational. There are other fancier things that you might need to do to help re-regulate her immune response. Dr. Laval will talk about that when he speaks on Triad 2, which is gut, immune, brain. But these are the features that I want you to focus on when you're starting to think about, oh my gosh, I got a Betty R and she's autoimmune thyroid. And sure, I have to deal with her stress, blood sugar, and thyroid proper. How do I do that? But also, how did she get in this mess in the first place? Well, maybe it was just that she was, following the food pyramid, eating a lot of gluten. So it could be as simple as pulling gluten out of the diet, sealing up the gut lining, managing her stress and thyroid issues, getting her off the armor temporarily so that we let things calm down, offload the pressure on her immune response, rebalance Triad 1 so she can regain control of her metabolism and she can start feeling better and losing weight. Pretty simple and straightforward, but when you put it in context, it really starts to make a lot of sense. So in addition to that, you can also consider adding in lots of good magnesium. So magnesium itself has been shown to blunt TPO production. Sterols, which are pine bark extracts, also help balance TH1 and TH2 in the setting of autoimmunity. Astragalus can do that as well. So once again, key concept, in presence of TPO antibodies, do not use prescribed or over-the-counter glandulars. I think that this is a prudent way to manage these patients because your real goal is to say 2 things to yourself. 1, she's in a deeper metabolic conundrum because of the expression of her autoimmunity. And 2, what are the factors that led her to that in the first place, and how do I manage them? And I think part of that is to say, well, let me offload some of the factors that might be worsening that. What do we do about her flattened cortisol curve? We definitely have to get her an adaptation, probably some DHEA as well, and then maybe a glandular or 2, depending on her energy levels. How do we manage her blood sugar? Well, we've talked about this. Really good baseline multi-mineral multivitamin, magnesium, chromium, and vitamin D, depending on the state of her blood sugar and insulin related to cortisol as well, maybe some alpha lipoic, and or if she has frank diabetes, bitter melon, or bergamot. We want to add tyrosine when adrenals and thyroid are low due to preferential consumption. I've said this several times before. I think it's really important. You'd be surprised how quickly the brain lights up when we add back in a little bit of support for dopamine. So what are we going to do for Betty R? Well, caveman diet, trace minerals and vitamins, selenium as well for blood sugar. For thyroid, selenium, methionine, iodine, tyrosine, maybe some sterols as well to help balance her immune response. There's a variety of compounds that do that. Sterols is just one choice among many. Get her off the armor, that's key. So for me as a prescriber, compounded T4 and T3. And then for her stress response, you could consider a glandular, definitely an adaptogen, tryptophan, and DHEA. So hopefully now you can understand the complexity of adrenal thyroid pancreas, how it progresses from early to mid to late stage changes. What are your typical lab findings in that regard? How do you emphasize different aspects of treatment depending on the initial patient presentation? And where are you trying to go in terms of rebalancing this in terms of lifestyle changes, dietary recommendations, stress management, and also beginning to support her metabolic pathways so that we restore normal response within insulin signaling, stress control, and thyroid function. What will happen is patients will start losing weight, they feel more vital, they have greater energy, and you'll see the beautiful results of this over time. And so Usually it's a matter of kind of mapping out, okay, I think this is a Triad 1 patient, reaching for too many carbohydrates, been under some stress, thyroid's starting to struggle. Here are the things that I need to do to organize my therapies, and I can quickly pull them back from the edge. Now, if they've expressed some real immune dysfunction, you got more work to do. And you have to really focus on those underlying features and factors that have to be addressed within the context of that. We will talk about that in greater detail as we go into the other triads, especially gut, immune, brain, which often relates directly to autoimmune processes. But this is a nod to the notion that a Triad 1 imbalance can spill into a Triad 2 balance of gut, immune, brain. So this is how we begin to archetype our patients, subsegment their metabolic activation pathways, begin to draw some lines around key features of their physiology, and take a more systems biology approach to their illness. And again, I had sort of talked over to some degree the details of the stress response in particular. I'd refer you back to the stress and neuroinflammation talk to see those links more clearly, to say, yes, stress affects the brain, it affects the immune system, and of course it affects other bodily systems as well. And so hopefully this lecture will help you better characterize these patients that are having lifestyle-related issues that are impacting these three features of their metabolism: Adrenal-Thyroid-Pancreas, cortisol, insulin, thyroid hormone, stress, metabolism, sugar. So thank you very much for your attention. I hope you continue to stick with us in our professional education series on behalf of Da Vinci, and I look forward to speaking to you again in the near future.